The epithelial tissue can be simple epithelium or it can be stratified. Simple means it is a single cell layer and stratified means it is multiple layer. In the simple itself, it can be simple squamous or flat cell epithelium, or it could be simple cuboidal or simple columnar. First we'll be focusing upon the simple type of epithelia. Later we can focus upon the multi-layered, stratified as well. But first, the single layer epithelium, which is called simple epithelium. Squamous means it is a flat cell epithelium and mostly having the flat nucleus. But not necessarily it is flat. The nucleus can be globular as well. Though we are expecting it to be flat because the cytoplasm is very minimal. To compare the squamous with the cuboidal and simple columnar, you can see the cytoplasm, which is above the nucleus, is minimal in case of squamous epithelium. As we notice, the cytoplasm of the nucleus is minimal, which is of moderate amount if it comes to the cuboidal. So cytoplasm above the nucleus is moderate in amount. And if you compare it with the cytoplasm of the nucleus in the columnar epithelium, then it is large amount of cytoplasm. You can mention here a large column of cytoplasm is there. Plus there is one more method of differentiating between the three. In case of columnar epithelium, the cell is like a column. You will see the height of the cell is more than the breadth of the cell, and that is a feature of a geometrical figure, the column. So height is more than the breadth. If the height is equal to the breadth, then we will call it as cuboidal epithelium, as evident here. The height of the cell is equal to the breadth and it is like a cuboidal geometrical picture. Whereas in case of squamous epithelium, it is a flat cell with flat nucleus. Another differentiation can be done by looking at the nuclei. As we mentioned, in the squamous epithelium, the nucleus can be globular, but usually it is a flat nucleus. If you compare this flat nucleus in the squamous epithelium with the cuboidal cell, there is a central spherical nucleus. So in cuboidal epithelium, there will be a central and spherical nucleus in the cell, whereas in case of columnar, it is oval and basal nucleus. That means the nucleus is towards the base, not the apex, and it is oval. So there is oval nucleus in the columnar, there is a spherical nucleus in the cuboidal, and there is a flat or globular nucleus in the squamous epithelium. Now we will be drawing this diagram ourselves, but first let us look at one MCQ asking us about the thyroid follicles to be lined by which type of epithelium. So here what we find is we can have three answers. It could be squamous, cuboidal, and columnar. Now if you say the answer could be any of the ABC, then which one is the best possible answer? In that case, we'll choose our answer as choice number B. But why you have taken your answer as simple cuboidal? Why not squamous? And why not columnar? Let us look at a diagram of thyroid follicles and find out that why the answer should be simple cuboidal if nothing is specified in the question. And the diagram comes now. Looking at the normal thyroid follicles, which are supposed to secrete the thyroxine hormone along with some protein. This is the lumen of the follicle where you'll have the thyroglobulin with thyroxine hormone. The follicle itself is lined by the cuboidal cells. These follicular cells are cuboidal cells. But how do you know they are cuboidal? Because you see the nuclei are central and spherical. So central spherical nucleus. You mean to say the height of the cell is equal to breadth of the cell? Yes, that is the feature of cuboidal epithelium. But they can become columnar as well. If there is more of thyroxine production, you will have more of endoplasmic reticulum, the height of the cell will increase and they become columnar. And what if it is a resting follicle, is not producing more of thyroxine? Then the height will reduce. It may be simple squamous epithelium. So height of the cell depends upon the function of the cell. But mostly we should choose our answer as simple cuboidal epithelium in the thyroid follicles. Let me take you to another question and tell me what is the answer to that one. The secreting active thyroid follicle. Now be careful here. The stem of the question is modified and in this case you have to change your answer. If it is mentioned secreting active thyroid follicle, it will have more of endoplasmic reticulum, increasing the height of the cell, more of cytoplasm above the nucleus, and hence it should be simple columnar epithelium. Let us draw the diagram ourselves. Like this is the basement membrane here, and we are having a flat cell with flat nucleus. This will be what we are calling as simple squamous epithelium, a flat cell with flat nucleus, which can be seen if the follicle was not very active, resting follicle. Now, if it is moderately active follicle, then you'll see the height of the cell becomes equal to the breadth of the cell, and there is a central spherical nucleus. So, simple cuboidal epithelium, which is having a central spherical nucleus, and height of the cell is equal to breadth of the cell. Normally, if anybody is asking us about thyroid follicle, we should answer it as simple cuboidal. And when will you answer it as simple columnar? It is actively secreting thyroid follicle. And how will you identify simple columnar? In here, you will find that the height is greater than the breadth, and there's an oval basal nucleus. So, oval basal nucleus and height is more than the breadth. This is a simple columnar epithelium. And why the height has become more? Because of more amount of endoplasmic reticulum. And why it is more? Because of more secretion. As the cell is getting more secretion, it will require more of endoplasmic reticulum, and it will require more of cytoplasm of the nucleus. And it becomes simple columnar epithelium. Let us now move on to some more details on the simple squamous epithelium, some other sites where we will find this type of epithelium. And consequently, we can talk about simple cuboidal and simple columnar, the other sites, the other locations where they can be found. But first, we start with simple squamous epithelium. And here we are looking for the simple squamous epithelium, the various sites it can be found. Let us zoom this area a little bit. And as is evident, it is present in the mesothelium. We have discussed that earlier as well. There are some body cavities like peritoneal cavity, pleural cavity, or pericardial cavity, having the pericardium, pleura, or peritoneum together considered as the mesothelium. And mesothelium is simple squamous epithelium. Even the endothelium, which is lining the blood vessels or the interior of the heart, is simple squamous epithelium, and so is the loop of Henle. In the kidney, we have the nephrons, and the loop of Henle is simple squamous epithelium. Even the fifth layer of the cornea, innermost layer of cornea, is simple squamous epithelium. The lung alveoli are also lined by most of the surface of lung alveolus is simple squamous. But why do you need simple squamous epithelium in the alveolus of lung? Because that is where we have respiratory gas exchange taking place. You need a thin membrane to facilitate the diffusion of gases. And when we are looking at the histological picture, we should find that it is a flat cell with flat nucleus. But here I am finding it is not a flat nucleus. It is appearing globular. Yes, that's what we mentioned. It is a flat cell with flat nucleus, but not necessarily the nucleus is flat. It can be globular also. But then, can't it be the cuboidal epithelium? No, it is not cuboidal epithelium, because if you look at the cytoplasm above the nucleus, it is very scanty. So, as we zoom here, you see this is the nucleus, and the cytoplasm which is above that is scanty. If it was cuboidal cell, then you will have moderate amount of cytoplasm. Plus the nucleus will be central and spherical. It will be evident in the next diagram, which is for simple cuboidal epithelium. And as you notice, this is the nucleus, central spherical nucleus. The cytoplasm above that is moderate amount, and the height of the cell is equal to the breadth of the cell. Where do you find simple cuboidal epithelium? As we zoom here, we can see most of the glands and their ducts. The initial part of the duct will be simple cuboidal epithelium. Like one example is sweat gland or the glands of the pancreas. Usually it is the serous glands which will be having simple cuboidal epithelium. And the ducts in the beginning will be simple cuboidal, though later they can become stratified cuboidal. Then when it comes to the kidney tubules, where exactly? It is actually proximal convoluted tubule and distal convoluted tubule. Both of them, as magnified here, will be having the simple cuboidal epithelium. Height of the cell is equal to breadth of the cell, and there is a central spherical nucleus, may it be PCT or DCT. Then we know the thyroid follicles themselves were usually lined by simple cuboidal epithelium, though they can become more secretory and columnar sometime, or maybe simple squamous at few of the occasions. And now let us move on to the locations where we can have simple columnar epithelium. The simple columnar columnar epithelium, as we have seen earlier as well, can be seen in the gut tube, like the stomach, the intestine, even the gallbladder. And when we are talking about the genital tube, like uterine tube, or the renal tube, the collecting ducts of kidney, there we have got simple columnar epithelium. Now, there can be variations, like in the uterine tube, we have got additional cilia. And when we are talking about the intestine, especially the small intestine, we have mentioned there can be microvilli to increase the surface area of absorption. We mentioned these microvilli are absent in the stomach. They are absent in the large intestine. They are seen in the small intestine. As you see in this diagram, first of all, we have to find out that this is simple columnar epithelium. As you notice, the height of the cell is more than the breadth of the cell, and there is oval basal nucleus. Now, theoretically, it should be towards the base, but as you can see, not necessarily. Here it is moving almost to the middle of the cell. But we know it is columnar epithelium because we have learnt if you have abundance of cytoplasm above the nucleus and the height of the cell is more than the breadth of the cell, then it is simple columnar epithelium. You see, there is abundant cytoplasm above the nucleus, hence qualifying as simple columnar epithelium. And these microvilli, they are producing a deeply pinkish margin on the apex of these cells. As we mentioned, these microvilli are basically to increase the surface area of absorption, as can be seen in the small intestine, more so in the jejunum part of small intestine. So this is simple columnar epithelium, height more than the breadth, oval basal nucleus, not necessarily basal, can be in the middle, but abundance of cytoplasm above the nucleus. Stratified epithelium means it is multiple layered cell epithelium sitting on the basement membrane. Like as we see here, we can have multiple layer of cells. But then there are some intermediary stages as well. Like you see here, this epithelium here is pseudo-stratified. Pseudo-stratified means it is giving the appearance of stratified but is not. And what does that mean? That means the cells, each of them will be attaching to the basement membrane. And if the cells are still attaching to the basement membrane, then you cannot call it as multiple layered, though they appear as multiple layered. So giving a false impression of being stratified, hence called pseudo-stratified. Even the transitional epithelium, though it appears multiple layered, but it is seen that the cell which are towards the lumen, even they have some cytoplasmic extension and reaching the basement membrane. So even the superficial most cells, they are having some cytoplasmic extension attaching to the basement membrane. It cannot qualify as proper stratified. We'll be talking about transitional epithelium in detail, and so we'll be doing about pseudo-stratified as well. But here, when we are talking about proper stratified, it is seen cells are sitting above each other and the superficial cells towards the surface has no cytoplasmic communication with the basement membrane. And as we have seen, the stratified epithelium can be non-keratinized versus the keratinized. In the keratinized, the superficial cells will be dead cells with no nuclei, whereas if it is non-keratinized, even the superficial cells are living cells and they do have nuclei comparatively. So where do we find this stratified squamous epithelium? Let us look at some of the sites. The stratified squamous epithelium, multi-layered cells, as we search for the locations, we already know it is present on the skin and the oral cavity. If you remember, we have discussed that on the skin, it is dry surface, hence keratinized, whereas in the oral cavity, maybe in the beginning, it is keratinized, but deeper and towards the esophagus, it is becoming non-keratinized. So, deeper oral cavity or esophagus, it will be non-keratinized, stratified squamous epithelium. Actually, there is a rule, it says any external opening in our body will be lined by stratified squamous epithelium. Like one we have seen, the oral cavity, even the opening of nasal cavity or the eyes or the ear. These four openings, they are all lined by stratified squamous epithelium towards the surface. And there are three openings in the perineum, the urethra, vagina, anal canal. Even those openings, they'll be lined by stratified squamous epithelium, as you notice, may it be the anus, the vagina, or the urethra at their opening. So 7 openings in the body, 4 on the face, 3 on the perineum. These 7 openings, they are all lined by stratified squamous epithelium. Here we have magnified the dorsum of the tongue in the initial part, and let us see the arrangement of the cells then. We mentioned stratified squamous epithelium. As you will notice, the basal cells are having oval basal nucleus, and this is a columnar epithelium, whereas the middle cells are having central spherical nucleus. So it is cuboidal epithelium, and the cells towards the surface are having flat nucleus. So we will call it as squamous cells. You can draw this yourself. This is the basement membrane here, over which we are having the columnar cells as rentified by the oval basal nucleus. So these are the basal layers on the basement membrane, whereas in the middle you have cells with central spherical nucleus. So they are cuboidal cells, and when we are looking at the surface cells, they are flat cells with flat nuclei, hence squamous. So towards the surface we have squamous cells, whereas in the middle we have the cuboidal. Towards the base they are columnar. This is how the stratified squamous epithelium will appear. So it is evident that this multiple layered epithelium, it is a cell which are towards the surface that is giving the name of epithelium, the stratified squamous epithelium. Though this epithelium has columnar as well as cuboidal cells, but it is a superficial cells which are taken as designation of the epithelium. In this question we are being asked about the epithelial lining of the lingual surface of epiglottis. Epiglottis is like a lid over the larynx, and it is having 2 surfaces, one towards the oral cavity, towards the tongue, and once towards the larynx, the respiratory tube, and it has double epithelium. The surface which is towards the tongue or oral cavity will have the same epithelium. If you say lingual surface of epiglottis will have the same epithelium as the tongue, that means stratified squamous epithelium. But what about the laryngeal surface towards the larynx, the respiratory tube? Then that will be having the respiratory epithelium. Whatever epithelium the larynx is having, and which one? That will be pseudostratified ciliated columnar epithelium. But then what is the answer to the question here? If you say lingual surface, just like the tongue, it is going to be stratified squamous epithelium. The answer is choice number D. And what if the question was changed and instead of lingual, they were mentioning the laryngeal surface? If it is laryngeal surface, then the laryngeal epithelium or respiratory epithelium, which is choice number B. The pseudo-stratified ciliated columnar epithelium is the respiratory epithelium. You'll find it in the larynx and even laryngeal surface of epiglottis. But since the question is lingual here, the tongue surface, so keep your answer as choice number D. And now let us move on to look at some features of respiratory epithelium as well in the next diagram. Pseudo-stratified ciliated columnar epithelium. Where do we find such an epithelium? In the respiratory tube, as we have mentioned. And along with the respiratory tube, where else? Actually, in the respiratory tube, it will begin in the nose region, moving on to the larynx, the trachea, the bronchus. Beyond bronchus, it will be changing further, but till bronchus. This is the epithelium we are getting. So, nasal cavity, trachea, bronchi. What about this male reproductive tract? Yes, even in the male reproductive tract, for example, epididymis. Which kind of epithelium is there in epididymis? It is pseudo-stratified ciliated columnar epithelium. But there, the cilia are called as stereocilia. There's a difference. So in epididymis, you are having stereocilia. What is there in the respiratory tube? These cilia. And why do you need these cilia? For mucociliary clearance. As we have mentioned, when we breathe the air in, there can be dust particles, some of the pathogens. You have to cough them out. Mucociliary clearance. And how do you know this is pseudo-stratified type of epithelium? Let us draw this diagram ourselves. First, we will show the basement membrane, and on the basement membrane, we find the cells are having different heights, and because of the different heights, the nuclei are at different levels. Some of these cells are shorter, then there are taller cells, and because of their height, the nuclei are going at various heights, giving the wrong impression of being stratified. But even the cells which are towards the surface, they have cytoplasmic extension touching the basement basement membrane. So it is a single cell layer but appearing stratified because of the different placement of nuclei. As you notice here, we can magnify this diagram. You find the nuclei are at various levels. Towards the base, in the middle, slightly higher, and reaching almost towards the apical level. So this multiple level of nuclei gives us the wrong appearance, the pseudo appearance of being stratified, but each cell is attached to the basement membrane, so cannot qualify as stratified. It is pseudo stratified and ciliated columnar epithelium. They will have some goblet cells also. If you wish, you can draw the goblet cells appearing like a goblet and having some mucus there. It is this mucus which will be moved by the cilia. And that is why the respiratory epithelium is called as pseudo-stratified ciliated columnar epithelium with goblet cell. This is the epithelium we'll be finding on the laryngeal surface of the epiglottis. We said epiglottis has double surface, one towards the tongue anteriorly and one towards the larynx posteriorly. So it is a posterior surface or laryngeal surface of epiglottis. The lid over the larynx will have pseudo-stratified ciliated columnar epithelium with goblet cell. Anteriorly, we already have mentioned the lingual surface is just like the tongue epithelium, stratified squamous epithelium. Now, talking about the transitional epithelium, we have mentioned earlier that it is a stretchable epithelium, and one example we have seen was in the urinary bladder. We are taking the specimen from here and we are enlarging it further and will be still magnifying it. We have to understand that the epithelium here can be having 8 to 10 cell thick appearance, but it can change into 2 to 4 cell thick appearance also. And why is that happening? Let us look at the next diagram. It is understood that if the urinary bladder was having very little urine, it is a relaxed bladder, then the lying epithelium can be 8 to 10 cell layered. But even the superficial cell will be sending cytoplasmic extension reaching the basement membrane. And since each cell is attaching to basement membrane, it does not qualify as stratified. It is called transitional epithelium. As it transitions, you see when there is urine in the urinary bladder, it is stretched. Now the thickness of the epithelium is 3 to 4 cell. So it is undergoing transition from 3 to 4 cell into 8 to 10 cell depending upon the presence or absence of the urine. Now it can give us the wrong appearance and we can get confused it with the stratified squamous epithelium. Then how do we differentiate it from stratified squamous epithelium? See, in stratified squamous epithelium, the topmost cells are squamous cells with flat nucleus, which is not the case in transitional epithelium. The superficial cells, the topmost cells, are not flat cells with flat nucleus. They are actually very large cells, globular cells, and there is ample amount of cytoplasm above the nucleus. We understand in squamous cells, there will be very thin peripheral rim of cytoplasm. So this is not a squamous cell. And moreover, these cells, they appear like umbrella-shaped cells. Let us draw it here. As you look at these cells, they give the appearance of an umbrella, as evident here, or more evident in this diagram here. So this kind of appearance, which you find, the umbrella-shaped cells, they are typically seen in the transitional epithelium. And these are, though appearing as squamous cells, but they are not, since they are globular cells, very large cells, especially seen when the urinary bladder is empty. So this is the transitional epithelium as seen in the urinary bladder. It is also present in the ureter and the proximal urethra and certain other locations as well, which we'll be describing later. At the moment, let us compare the transitional epithelium with the stratified squamous epithelium. How will you differentiate different type of epithelium if given together? Here we compare the transitional epithelium with the keratinized stratified squamous epithelium. And what is the difference between the two? You see, if it is a transitional epithelium, then the cell towards the lumen, the surface epithelium cells are globular, umbrella-shaped cells. They are quite large, globular and umbrella shape. You are comparing it with the which epithelium? The stratified squamous epithelium. As we see here, the cells at the surface are flat cells with the flat nucleus. So, in higher magnification, you can make out the difference between the superficial cells. Otherwise, they give the appearance of being stratified and can be confusing. There is one more difference you can see. You look at the transitional epithelium, the basement membrane is going almost straight. But if you are looking at the skin epithelium, which is keratinized stratified squamous epithelium, the basement membrane, is not going straight. It is having some papillary appearance because of the subepithelial connective tissue, the dermis having a papillary layer of dermis. So sometimes we have to use multiple methods to differentiate between the various type of epithelia. Here it is transition epithelium, which you can find in urinary bladder. That is the stratified squamous epithelium, which can be found in the skin. Then what is this epithelium? This is the respiratory epithelium, pseudostratified ciliated columnar epithelium, as you can see the cilia here, which you have to differentiate from the keratin. The keratin is longitudinally present over the surface, whereas the cilia are thread-like processes which are going vertically upwards. So this is pseudostratified ciliated columnar epithelium with goblet cell, the respiratory epithelium. And my point is, you have to practice looking at various type of epithelia so that if they are given together, your eye should be able to identify them as soon as possible, because the examiner are giving these epithelia and asking for the various sites where they can be found. And that is why practicing MCQs is of utmost importance. Now we proceed further with this epithelium, stratified squamous epithelium. And if you remember, we had a rule: any external opening in our body is to be lined by stratified squamous epithelium. And we were discussing 7 of them, 4 on the face and 3 in the perineum. Let us continue further with that. Let us note down the rule here, which mentions any external opening in our body is to be lined by the stratified squamous epithelium. But then if you remember, embryologically we have mentioned any external opening should be derived from surface ectoderm. So whenever there is an external opening, you will have the lining of surface ectoderm. It also means wherever you will have surface ectoderm, you should have the stratified squamous epithelium. So basically, one rule is for the histology and one rule is for the embryology. And what we derive is wherever we have surface ectoderm, that location must be lined by stratified squamous epithelium. But now be careful. It is not the other way around. Means the stratified squamous epithelium is not only present on the ectoderm, but it can be present on mesoderm and endoderm as well. Say, for example, you take the case of the vagina. When we talk about the embryology of vagina, upper vagina is coming from the mesoderm and the lower vagina is coming from the endoderm. But then entire vagina is lined by the stratified squamous epithelium. It means stratified squamous epithelium can be present on ectoderm as well as mesoderm and the endoderm. Let us draw the diagram for the vagina, the genital tube here, and mention this is the uterus and here is the vagina. And we understand that our vagina is from the mesoderm and the lower part of vagina is from the endoderm. Now, some of the students might get confused and mention, since the vagina is an external opening, it should be lined by surface ectoderm. Yes, you are correct. But understand, vagina doesn't open to the exterior immediately. It is covered by labia minora and labia majora. It is the minora and majora. They are lined by surface ectoderm, not the vagina itself. Let us draw them here. The vagina is covered by labia minora and labia majora, as you show on either side. This is labia minora, labia majora, and it is those surfaces which are lined by the surface ectoderm. The vagina itself does not have any ectoderm, despite the fact that it is an external opening. So there are rules and there are some exceptions as well. And wherever you have exceptions, they become the questions. So understand, upper vagina is from mesoderm, lower vagina is from endoderm, and it is the labia minora majora which are lined by surface ectoderm. But all of this, maybe the majora minora or the vagina, entire surface is lined by stratified squamous epithelium. Actually, you better remember, stratified squamous epithelium is present at any surface which is prone to abrasions, and the multilayered epithelium is protecting us against the abrasions. And talking about the exceptions, there is one more surface which is prone to abrasion, the vocal cords. Let us talk about the vocal cords as well. You know, in the larynx, there is a narrow opening which is in the region of vocal cords. And as the air is moving, especially while we are coughing and sneezing, the air is moving at high speed. That time, this opening, the vocal cord, that narrow surface, is prone to abrasion. And that is why the vocal cords themselves are lined by stratified squamous epithelium, despite the fact that entire larynx itself is respiratory tube is lined by respiratory epithelium. So, larynx is lined by respiratory epithelium except at the vocal cord. And vocal cord itself is a special location which is prone to abrasion, hence to be lined by stratified squamous epithelium. So, what is the exception here? See, we have mentioned the stratified squamous epithelium is present on external opening. But then, is vocal cord an external opening? No, it is an internal opening. So, even internal openings can have stratified squamous epithelium, and they are the exceptions. So, overall, generally speaking, when we say any external opening, it must be lined by the stratified squamous epithelium. It must be lined by surface ectoderm. That is a generalized rule, but these rules can have exceptions. As we mentioned, stratified squamous epithelium can be present on structures derived from mesoderm, endoderm, like the vagina. Vagina has no ectodermal origin as such, but is lined by the stratified squamous epithelium. And then, not necessarily any external opening. It can be internal opening also, like vocal cord, to be lined by stratified squamous epithelium. But then, let us not focus upon exceptions here. Let us look at 7 opening in our body, 4 on the face, 3 in the perineum, and then we can discuss that they should be lined by stratified squamous epithelium. We'll be drawing some diagrams for the purpose. Let us first look at the 4 openings which are there on the face to be lined by the stratified squamous epithelium. As we are mentioning, this type of epithelium is protecting us against the abrasions, and some of the openings, they are prone to abrasions. Like you can mention the eyes, then the ear and the nose and the oral cavity. And you can draw it diagrammatically as well. So, as we draw the face here, we are telling these are the eyes, the nose, the ear and the mouth. Now, in the eyes, on the outer aspect, we have the cornea. And this cornea is having 5 layers. The very first layer of cornea towards the exterior is lined by stratified squamous epithelium because it is prone to abrasion. So, you can mention the first layer of cornea is to be lined by the stratified squamous epithelium. Now, coming to the ear, we understand external auditory canal and the outer surface of tympanic membrane. Both are lined by the stratified squamous epithelium. You can mention them here. The external auditory meatus and outer surface of tympanic membrane is lined by stratified squamous epithelium. Now, once you mention them, external auditory meatus and the tympanic membrane, but on the external, what about the internal surface of tympanic membrane? If you are talking about internal surface of tympanic membrane, it will have same epithelium as the middle ear cavity. Then what is the epithelium of middle ear cavity? Middle ear cavity can have several types of epithelia, but in this region it is simple cuboidal epithelium. So the point is, tympanic membrane on the interior is simple cuboidal epithelium, but on the exterior is stratified squamous epithelium. So tympanic membrane has double epithelium, and as per rule, if it is to the exterior, it must have stratified squamous epithelium. Now, what about the nose? The opening of the nose, nasal vestibule, where you have some hair as well, is stratified squamous epithelium. You can mention the nasal vestibule, put a star mark here, and mention that the nasal vestibule, which is having some hair as well, is true skin. And if it is true skin with hair, then of course, it will be lined by stratified squamous epithelium. Then you can come towards the oral cavity, and in oral cavity, you mention 2 regions, one just at the opening and one deeper. Say for example, the hard palate and dorsal of the tongue at the beginning, and then you can mention the deeper structures as well, like the deeper is soft palate and the deeper tongue. Not only that, but you can also mention along with the posterior tongue, the lingual surface of epiglottis. We have discussed this earlier as well. So may it be the lingual epiglottis or the posterior tongue or the soft palate. What is it lined by? All the structures in the old cavity are lined by stratified squamous epithelium. But here you have to understand, if it is at the opening, just at the entry point, it will be keratinized. So this hard palate and the dorsum of the tongue in the beginning are keratinized. Whereas if you are talking about the soft palate, which is deeper, and the deeper tongue or lingual epiglottis, they are non-keratinized. And as we mentioned here, all these structures, they are kept wet because of some secretions like saliva. Now this keratinization which you are telling in the hard palate or dorsum of the tongue, is it proper keratinization like skin, or is it different? It is different. It is called as orthokeratinization, parakeratinization. And how do you identify histologically it from the normal keratinization? We have got a histological diagram now. Let us look at that. And here you see that this portion of diagram is showing keratinized epithelium, whereas here we have got parakeratinized epithelium. It is kind of a junction which you can mention on the exterior, like this is the true skin, keratinized epithelium, and as you are moving inside the oral cavity, say towards the hard palate, then you are having the parakeratinized epithelium. So what is the difference between the two? You know, skin, the keratinized epithelium, the superficial cells are dead desquamated cells and they have no nuclei. But if you talk about the parakeratinization, orthokeratinization, like on the hard palate, you will see that despite the presence of keratin, the superficial cells, they are having the nuclei. So you can mark them here. If the superficial cells are having the nuclei, despite the fact that you have some keratin here, you will call it as parakeratinization or orthokeratinization. Whereas in the normal keratinized skin, you don't have nuclei in the superficial layers. So this is the true skin with no nuclei in the superficial layers, but this is keratinized stratified squamous epithelium, but a different type of keratinization, orthokeratinization, parakeratinization, where even the superficial cells, they are definitely showing some nuclei. And now let us move on to the perineum region. We want to look at the three openings in the perineum, especially the female perineum. We were talking about the 7 openings. We have seen 4 on the face and now 5, 6, 7 on the perineum. Here we are looking at a female perineum in lithotomy position, and we know that there are 3 tubes opening here. The renal tube as the urethra, the genital tube as the vagina, and the gut tube as the anus. And all of them, may it be the urethra or the vagina or the anus, they are all lined by stratified squamous epithelium. Let us draw this diagram ourselves as well. And we put the number 5, 6, 7 because we have discussed there are 7 openings to be lined by stratified squamous epithelium. Here it is the urethra more anterior, in the middle we have the vaginal opening, and posteriorly it is the anal opening. And we are showing it in the diagram as well. Now, since we are talking about a female here, the female urethra is quite short. It is only 4 centimeters in length, and that is why it is entirely lined by the stratified squamous epithelium. But that is not the case in a male, because male urethra is quite long. It is actually 20 centimeters long. And in that 20 centimeter, only the tip of the male urethra is lined by stratified squamous epithelium. Now, if only the tip of the male urethra is lined by stratified squamous epithelium, what about the entire length of the male urethra? In fact, most of the male urethra is lined by stratified columnar epithelium. That should be your first answer. So, whenever a question comes, what is the male urethra lined by? Your first answer should be stratified columnar epithelium, because that is the lining for the entire male urethra except the initial part and the distal part. In the distal part, we have already mentioned, since it is an external opening, the tip of male urethra will be lined by stratified squamous epithelium. We'll be talking about these details once again. This is just an overview here. And now, what about the vagina? Vagina, we have mentioned earlier. It is entirely lined by stratified squamous epithelium. And what about the anal opening? Even the anal opening is lined by stratified squamous epithelium, but then anal canal is a long structure and it has got a dentate line, what is also called as the pectinate line. So below this dentate line or pectinate line, which is towards the exterior, the anal canal is lined by stratified squamous epithelium. The rule says any external opening. So this is the external opening of anal canal. Below the teeth-shaped dentate line or pectinate line, you do have stratified squamous epithelium, but not above that. Above the dentate line, you have got what is called as transition zone. zone, an anal transition zone, the epithelium is different. Now, what kind of epithelium is there? We will discuss later. At this moment, we just wanted to know openings like urethra, vagina, and anal canal should be lined by stratified squamous epithelium. Actually, we have to understand that there are some squamo-columnar junctions. The squamo-columnar junctions. And whenever there are squamo-columnar junctions, maybe in the urethra, in the anal canal, the terminal anal canal, or the beginning of gut tube, like at the lower end of esophagus and stomach, we have squamo-columnar junction. These junctions are prone to dysplasia, metaplasia, cancer. So let us focus upon these transition zones, the squamo-columnar junctions now. So as I mentioned, squamo-columnar junctions, they are prone to dysplasia, then metaplasia, and which can then become cancer. And there are some locations which we need to be careful about. Like we just mentioned, the anal canal or the esophagus or even the uterine cervix. They are all prone to cancer at these junctions. Actually, we have got a question on the esophagus. Let us look at that question and then proceed further with the discussion. What you are looking at is a very controversial question asking about the Barrett's esophagus. The diagnosis is based upon which of the following? And you will find that different standard textbooks give you different answers. Let us start with Gray's Anatomy. In Gray's Anatomy, it is written as the gastric metaplasia. So, are you going to take your answer as gastric metaplasia? No. You mean to say you are not going to follow the Gray's Anatomy? No. Sometime we have to contradict even the Gray's Anatomy. And why are you contradicting Gray's Anatomy? Because if you look into Harrison medicine or Bailey Love surgery, or there are 3 books which are giving the answer as intestinal metaplasia. So you mean to say intestinal metaplasia is a better answer? Yes, D is a better answer than C. But why D is a better answer than C? Because as I mentioned, the medicine book, the surgery book, the pathology books, they mention intestinal metaplasia. Let me take you to the paragraphs which I have taken from these books. But keep your answer as choice number D. If you don't find it, then make it choice number C. D is a better answer than C. There are 3 books going in favor of D and 1 book going in favor of C. And we are nobody to judge the correct answer. This is definitely a controversial question. And according to my experience, I'm telling you, it'll be better if we go for intestinal metaplasia as our first answer. Because let me show you the paragraphs now. This is Harrison medicine showing it as intestinal metaplasia. This is Bailey and Love showing it as intestinal metaplasia. And Pathology Robbins also mentioning the same. So I have got 3 books mentioning the Barrett esophagus as intestinal metaplasia. But if you look at the Gray's Anatomy, you find it is mentioning it as gastric metaplasia. Now, why the Gray's Anatomy mentioned it as gastric metaplasia? Let us find out in a diagram and then drawing the diagram ourselves as well. It is a case of GERD, gastroesophageal reflux disease, where the gastric acid keeps coming back into the esophagus and thus changing the lining epithelium of the esophagus. Now, normally the epithelium of the esophagus is stratified squamous epithelium, only the lower part of esophagus. Short length is having columnar epithelium. But if the acid keep coming up very frequently, then the stratified squamous epithelium may change into a longer length of columnar epithelium. So, squamous epithelium changing into columnar is a dysplasia which can be prone to metaplasia and cancer. Any such condition where you have gastroesophageal reflux disease must be treated as early as possible. Maybe you can use some pharmacological agents or some surgical treatment. Like you see, there can be a case of hiatus hernia, so surgical repair may be helping. Let us magnify this area to understand more details about this squamo-columnar junction. And as you do that, normally what you find is a Z line, zigzag line. It is called zigzag line as the appearance is zigzag here and is representing the squamo-columnar junction in a normal esophagus. We have to understand that the epithelium which is above that, this whitish mucosa at the lower end of esophagus, is stratified squamous epithelium, as you can mention here. But the lower 2 centimeter of the esophagus below the Z line is lined by columnar epithelium. So that is why we are telling that this is squamo-columnar columnar junction. And this area where you have this pinkish mucosa, pinkish is representing the columnar epithelium, whitish represent the stratified squamous epithelium. So squamo-columnar junction is at the lower end of esophagus, and this distance is normally 2 centimeter. What you see below this is the stomach epithelium, which is obviously columnar epithelium. Now the problem is, whenever there is a gastroesophageal reflux disease, this 2 centimeter of the columnar epithelium on the esophagus may be moving proximal. This Z line is moving proximal. The 2 centimeter may become 5 centimeter. And if this Z line becomes more proximal, that means the stratified squamous epithelium is being encroached by columnar epithelium. That area where stratified squamous epithelium is replaced by columnar epithelium is dysplasia, prone to metaplasia, is prone to cancer, adenocarcinoma at the lower end of esophagus. That is what we want to discuss here. So first we will look at the normal histology, and then we can talk about the pathology as well. In this diagram, we are once again looking at the zigzag line, the Z line, which is squamo-columnar junction in a normal individual, shown histologically here, the location of Z line. What it means is proximal to this whitish mucosa of the esophagus is lined by stratified squamous epithelium. You can mark it here. This is the lower esophagus and is lined by the stratified squamous epithelium. But then below that, about 2 centimeter of esophagus has columnar epithelium, the pinkish mucosa. So you can mark it here, the 2 centimeter region, and show here as well the columnar epithelium. And that is the point where you can mention gastroesophageal junction. The gastroesophageal junction. That means the squamo-columnar junction and the gastroesophageal junction, they are different. One is gross anatomy, one is histological anatomy. And of course, what is below this is the stomach and gastric epithelium, which is columnar epithelium. But this 2 centimeter of esophagus does have columnar epithelium. And if this columnar epithelium encroaches further, more proximally, if this columnar epithelium is replacing the squamous epithelium, changing into columnar, then that region is dysplasia, metaplasia, and prone to cancer. That is our discussion here. We are going to make this diagram showing the squamo-columnar junction or the Z line along with the gastroesophageal junction. The distance between them normally 2 centimeter, but in a case of GERD, that 2 centimeter has become 5 centimeter. The Z line is going more proximal, and this region becoming prone to adenocarcinoma esophagus. Let us draw this diagram ourselves now. Here we draw the diagram of the gastrointestinal tube starting from the oral cavity. As we understand, the oral cavity will continue as the pharynx. So you can mention here, this is the oral cavity, distally becoming the pharynx, which then continues as the esophagus. So here is the esophagus, which will have a junction with the stomach. So we can draw the stomach here, and which will then continue as the small intestine. That is the proximal duodenum. Now here you have got the proximal duodenum. This is the stomach. What about their epithelium? So this oral cavity, the pharynx, the esophagus will have different epithelium as compared with the stomach and small intestine. First, let us put here the gastroesophageal junction. And as you mentioned, this is the point where the esophagus is becoming continuous with the stomach. And about 2 centimeter above the gastroesophageal junction, we have a Z line, the zigzag line. So we are putting it here, the Z line, the zigzag line, which is actually called as squamo-columnar junction. Now, why would you call it as squamo-columnar junction? Because as we mentioned, the epithelium which you find in the oral cavity is continuing in the pharynx and into the esophagus. That epithelium is reaching till the Z line and a stratified squamous epithelium. Now, this stratified squamous epithelium from the oral cavity, pharynx till the esophagus does not reach the lower 2 centimeter of esophagus. Normally, anatomically, this is where you have the columnar epithelium, which is the epithelium of stomach and the proximal duodenum as well, the small intestine. So let us show it here. The small intestine and the stomach has columnar epithelium epithelium which is encroaching upon lower esophagus also normally. So this is the columnar epithelium, and that is why we are mentioning that the squamo-columnar junction is at the zigzag line, normal anatomical finding. You can write here, this distance should not be more than 2 centimeter. Now, if this is normally 2 centimeter, what is the problem? Problem is it is a case of GERD, gastroesophageal reflux disease, and some of the acid keeps coming into the distal esophagus, and because of this recurrent gastroesophageal reflux of the acid, the epithelium of the esophagus is changing. You notice that when you have taken a biopsy from the lower esophagus, it was actually found to be columnar epithelium, and you have labeled it as Barrett's metaplasia. You also notice that in the biopsy which you have taken for this region of esophagus, not only is having columnar epithelium, but it is also having goblet cell. So if you have columnar epithelium with goblet cell, that is the epithelium you find in the intestine. And that is why books like Pathology Robbins, Harrison Medicine, Bailey Love Surgery, they are calling this Barrett metaplasia as the intestinal metaplasia. Now, maybe you have mentioned it as intestinal metaplasia, but you are using a misnomer here. And why is it a misnomer? It is written by Pathology Robbins that despite the fact that you are calling it as intestinal metaplasia, it cannot be called so. And why? Because maybe it is having intestinal epithelium here. Is it doing any absorption? And because it is not doing any absorption, how can you call it as intestinal metaplasia? So that is why it is a misnomer when you call it as intestinal metaplasia. Despite having the epithelium similar to the intestine, it is not having the function of absorption. So it's a misnomer. Now, maybe it is a misnomer, but it is being used by 3 books. So we will continue calling it as intestinal metaplasia. Then what about Gray's Anatomy? Why Gray's Anatomy is calling this as gastric metaplasia? According to Gray's Anatomy, what they have found is that normally it is the stomach which is having the parietal cell, which is for HCl production. And they could find this parietal cell in a biopsy which was taken here at the Barrett esophagus. So their logic is, since the biopsy is showing parietal cell and parietal cell is present in the stomach, let us call it as gastric metaplasia. So they have their own logic calling it as gastric metaplasia. But then again, it is a misnomer. And why this time it is a misnomer? Because we could find even the goblet cell here. And normally you do not have goblet cell in the stomach. Stomach does not have goblet cell. Goblet cell are in the intestine, not in the stomach. And since the stomach do not have goblet cells, but you found the goblet cell in the Barrett esophagus, how can you call it as gastric metaplasia? So again, it is a misnomer, but it is being used by Gray's Anatomy. So it remains a controversy. Having parietal cell, so gastric metaplasia, but cannot be gastric because it also has goblet cell, which normally is not present in the stomach. So my advice is, whenever there is a question having gastric metaplasia and intestinal metaplasia in the option, the first answer should always be taken as intestinal metaplasia, a preference over gastric metaplasia.